Hello everyone, this is Dr. Prashanth and welcome back to Epidemiology lecture series. In this lecture, we will discuss about the topic screening. To begin with the definition, screening is the presumptive identification of unrecognized disease or defect by the application of tests, examinations or other procedures which can be applied rapidly to sort out apparently well persons who probably have a disease from those who probably do not. And a screening test is not intended to be diagnostic. Even after screening, persons with positive test findings must be referred to their physicians for diagnosis and necessary treatment. And the most important characteristics of a screening test are validity, reliability, and yield. Under validity, we see sensitivity, specificity, and predictive values. Now let's discuss about each of them in detail. To start with validity, a screening test should provide a good preliminary indication of which individuals actually have the disease and which do not. This is referred to as the validity of the test. So it has got two components, one is sensitivity and other is specificity. Sensitivity is defined as the ability of a test to identify correctly those who have the disease, whereas specificity is defined as the ability of a test to identify correctly those who do not have the disease. Both sensitivity and specificity are determined by comparing the results obtained by screening test with those derived from some definitive diagnostic procedure. So here we compare our screening test findings with that of some standard diagnostic test. So this is how it looks. Screening test versus the standard test. Under standard test, if I ask about the total positive findings, it is A plus C, whereas in screening test, the total positive findings will be A plus B. Now let's start with the important terms. One is prevalence. So when we talk about prevalence, it is nothing but those individuals who test positive with the standard test as a percentage of all individuals tested. So when we say test positive with the standard test, you go directly to the standard test column and see the total number of positive findings. It's A plus C, right? So prevalence is nothing but A plus C divided by the total individuals. So A plus B plus C plus D. Sensitivity. Sensitivity is the proportion of true positives correctly identified by the new test. According to standard test, the total positive findings are A plus C. Out of A plus C, how many cases are correctly identified by the screening test? How many positive cases? So here the sensitivity will be A upon A plus C. Specificity. Specificity is the proportion of true negatives correctly identified by the screening test. So now if you look under the diagnostic test, the total negative is B plus D, right? So out of B plus D, how many true negative cases are identified by the screening test? So it is D by B plus D. And now coming to the predictive values, the first one is the PPV or the positive predictive value. It is the proportion of individuals with a positive result who actually have the disease. So individuals with a positive result in this case, according to screening test, are A plus B, right? Out of these A plus B cases, how many are actually having the disease which was diagnosed by the diagnostic test? That is A. A upon A plus B. A actually having the disease and A plus B is the total number of cases which are positive according to the screening test. Similarly, negative predictive value is the proportion of individuals with a negative result who do not actually have the disease. So individuals with a negative result according to screening test are C plus D, right? So out of the C plus D cases, how many are actually not having the disease according to diagnostic test? That is D. D upon C plus D. Let's understand this with a small example. If you can see the 2x2 table, standard test was a screening test. Let's start with prevalence. As we know, prevalence is nothing but the total positive cases according to the standard test. So you go directly to the standard column, look after the positive cases, it's A plus C, right? It's nothing but 18 plus 2, 20 upon, and the total cases in this scenario are 1000. And coming to sensitivity, sensitivity is the true positives identified by the screening test. What are the total positives according to the standard? It's A plus C. That is 18 plus 2, 20. Out of 20, how many are correctly identified by a screening test? It's 18, right? So 18 upon 20. Similarly, when we talk about specificity, it's the true negatives identified by the screening test upon total negatives according to the standard test. It's nothing but D upon B plus D. 931 divided by 931 plus 49. It's 95%. And coming to the positive predictive value, it's A upon A plus B, right? 18 divided by 18 plus 49 according to screening test. It's 27. And coming to the negative predictive value, it's D upon C plus D. So the answer is 99. So all these terms are usually expressed in percentage, like prevalence is here 20%, sensitivity 90%, specificity is 95%, PPV is 27 and the NPV is 99.8%. Now let's look into the ideal test and also how to choose between sensitivity and specificity. How you come to know like whether I should choose more sensitivity or more specificity. An ideal screening test would be 100% sensitive and 100% specific. That means 100% we should be able to identify the true positive cases and also true negative cases, which is practically impossible. So in reality, both sensitivity and specificity are inversely related. That means we can achieve high sensitivity at the expense of low specificity and vice versa. Let's understand this with an example. Here I want to screen donated blood to look whether the blood is having HIV infection. That means we just want to screen those samples and check for the HIV. Here the test used was enzyme immunoassay, that is EIA, and the total population is 1160. Okay, this is how the table looks. The standard test versus the screening test what we have used. So let's calculate sensitivity and specificity. In this case, the sensitivity was 95%, whereas specificity is 98%. So let's understand what to choose, high sensitivity or high specificity, because in this case, it's showing high specificity when compared to sensitivity. So to get this, let's go back to the question where we want to test blood samples, right? So that we can identify those samples which are infected with HIV, so that we can prevent the transfusion of that infected blood to a healthy individual. Just because of that, we prefer sensitivity over specificity in this case, so that we can prevent HIV infected blood being given to another individual. So we need to use a test with the maximum sensitivity so that we detect as many of the HIV infected donated blood units as possible. As we already discussed, sensitivity and specificity are inversely related. In this case, if we are choosing maximum sensitivity, automatically the specificity will be less in this case. So what happens in this case if the specificity is less? Specificity is nothing but identification of true negatives, right? And if it is less, we fail to detect the true negatives. Even if the blood samples are free from HIV infection, we fail to detect that, so that some samples will be wasted. Now let's see how PPV and NPV are related to prevalence. As we already discussed about these predictive values, let's see the relation between the prevalence and the predictive values. Positive predictive values are directly related to the prevalence of the disease, or the predictive value of a test increases as the prevalence of the disease in the population increases. And now coming to NPV, negative predictive values are inversely related to the prevalence of the population, or the negative predictive value of a test decreases as the prevalence of disease in the population increases. And now coming to the next important characteristic, that is reliability. It is the extent to which a test will produce the same result if it is repeated. So there are two major factors that affect the consistency of any test result. One is variation inherent in the method, that is the method of screening. The variability of a method depends on factors such as the stability of the reagents used in the test and fluctuation in the substance being measured. And now coming to the second part, that is observer variation. So there are two types of observer variations. One is intra-observer variation, that is within the observer. Variation seen in the result if the same observer does the same measurement 2 or more times, whereas inter-observer variation is seen in the result if two different observers do the same measurement on the same subject. That is the difference between intra-observer variation and the inter-observer variation. And now coming to the last important characteristic of a screening test, that is yield. So let's understand what is the purpose of a screening. We do screening to identify those patients or those populations who are initially undiagnosed with those diseases, to identify them. We want to differentiate those people who are having the disease and who are not having the disease, right? So yield is defined as the amount of previously undiagnosed disease that is diagnosed and brought to treatment as a result of the screening. So there are many factors that affect the yield of a screening program. So some of them are sensitivity of the test, the prevalence of unrecognized disease in the population, and third is the multiphasic screening. In multiphasic screening, where for example, if you are doing a screening to identify cancer based on the location in the body, parallelly we try to take some samples, blood samples, or we try to check their weight or blood pressure. So in multiphasic screening, we do multiple screenings. Like, we work on multiple variables. And now coming to the next factor, that is the frequency of screening. If the population is screened recently, automatically the yield will be less, right? If the population is not screened for a very long period of time, So automatically when you do screening, the yield will be more. And the last and the most important factor is the community participation. Until and unless the community participates in a screening and understand the importance of a screening test, the yield is obviously less. Thank you.